Hello students, this is Dr. Sowkarthicaa, Assistant Professor, Department of Pediatrics, Vinayaka Mission Sowkarthicaa Dental College, Salem. Today moving on to the topic called fixed space maintenance. These are the contents of the slide. Moving on to the introduction. Children lost their teeth in their early childhood due to dental caries, trauma, infection and crowding. Maintenance of space created by the lost teeth, especially molars, is necessary till eruption of their permanent successors. The term space maintenance was coined by J.C. Breuer in 1941, whereas space maintenance as the process of maintaining a space in a dental arch previously occupied by a tooth or a group of teeth. Boucher in 1945 states that space maintainer as a fixed or removable appliance designed to preserve the space created by the premature loss of a primary tooth or a group of teeth. Martinez and Elsbach states that they are the orthodontic appliances used to prevent loss of arch length. Functions of sound primary teeth, which includes mastication of food, maintenance of a normal facial appearance, formulation of clear speech, maintenance of a proper diet, maintenance of a space and arch continuity for the emergence of permanent teeth. Flat root configurations of molars resist mesial migration and space loss, and it acts as a space maintaining appliance. Next is causes of premature loss, which includes dental caries, trauma, ectopic eruption, abnormal root resorption, systematic disorders or hereditary syndromes, which include hypophosphatasia, rickets, acrodynia, leukemia and cherubism. Next, moving on to space closure after premature loss. First comes rate of closure, whereas Seipel and Seward found that maxillary space closure is fairly constant with a slight tendency for the closure rate to slow after first year. Richardson in 1965 states that the space closure in the first 6 months is about 1.35 mm and in the second 6 months is about 0.86 mm and in the third 6 months is about 0.77 mm and in fourth 6 months it's about 0.59 mm. Next comes the amount of closure, whereas maxillary space closure is always greater than the mandibular space closure, which was given by Davy in 1967. Next comes indications and contraindications. First, moving on to indications, which includes premature loss of primary teeth, when the succedaneous tooth is not ready for the eruption and when there is at least 1 mm of bone coverage over the space created. Next is after space analysis, when there is possibility of space inadequacy for the permanent successor due to unbalanced force from the adjacent teeth. Next is contraindications, which include no bone coverage overlying the erupting permanent successors. Root of the succedaneous tooth has about 2/3 of completion and succedaneous tooth is absent and the space needs closure when the space created is less than the mesodistal diameter of the crown of the permanent successors. Next, moving on to ideal requirements of space maintainer. First comes the appliance should not interfere with masticatory function, should not inhibit or deflect normal growth changes, and it should be simple to construct and maintain, and it should be durable, strong and stable, and it should be passive and easily cleanable, and it should prevent the supra-eruption of teeth. It should improve aesthetics and assist in speech and maintain an entire mesodistal width of the lost tooth. And it should strong enough to withstand a masticatory force, and it should not give excessive stress to the adjacent teeth. Then factors considered in decision of space maintainer includes incidence of space loss, time elapsed since loss, dental age of the patient, amount of space closure, direction of space closure, amount of bone covering and congenital absence of the permanent teeth. Next, moving on to classification of space maintenance. According to Hitchcock in 1973, it was classified into either removable, fixed or semi-fixed, either with band or without band, either functional or non-functional, either active or passive, or a certain combinations of the above. And then according to Raymond in 1978, it was classified into removable, complete arch, lingual arch, extraoral anchorage and individual tooth. Then according to Hendrickson in 1962, it was classified into fixed space maintenance and removable space maintenance. Under removable space maintainer, it is an acrylic partial dentures, and under fixed space maintainer, it is classified into class 1 and in class 2. Again, that class 1 is subdivided into non-functional types, which includes bar and loop types, and functional types include pontic and lingual arch type, whereas in class 2 includes cantilever types like distal shoe, band and loop, whereas fixed unilateral appliances include band and loop, crown and loop, and distal shoe space maintenance. Whereas fixed bilateral appliances include transpalatal arch, transpalatal arch, and passive lingual arch appliances. Next, advantages and disadvantages of fixed space maintainers. Whereas space maintainers which are fixed or fitted onto the teeth are called fixed space maintainers. Its advantages include band and crowns are used with minimal or no preparation, and they do not interfere with passive eruption of the abutment teeth, and the jaw growth is not hampered, and the succedaneous permanent teeth are free to erupt into the oral cavity, whereas it is used in uncooperative patients, and masticatory functions is restored if phontics are placed. Disadvantages include it elaborate instrumentations with expertise skill, and it results in decalcification of tooth material under bands, and supra-eruption can take place if phontics are not used, and if phontics are used which interfere with vertical eruption of the permanent teeth if patients fails to report. And indications and contraindications include of band and loop, whereas indications was given by Moyers in 1988 in case of premature loss of any primary molars in primary dentition with permanent successes not erupting clinically for the next 2 years, and its root length is less than 1/3 mature. Next, premature loss of primary second molar as the permanent first molar is erupted clinically. Next, bilateral loss of single primary molar before eruption of the permanent incisors. Next is premature loss of canine. Next is when the period of space maintenance is short and abutment tooth is intact. Whereas contraindications include, which was given by Matthewson, an occlusion that is extremely crowded or already exhibits marked space loss, high dental caries activity, replacement of primary anterior teeth, replacement of primary second molar in the primary dentition without partial clinical eruption of the permanent first molar. Parts of band and loop include band, crib, and loop. Whereas band is made up of stainless steel material, whereas crib is a portion of wire spanning the edentulous space, whereas loop is a portion of wire contacting the abutment tooth about 0.36 inches in diameter. Armamentarium of fabrication includes stainless steel band material or preformed bands. Pliers include contouring pliers, band seater or pusher, band adapter, hoe pliers, beak pliers, crimping pliers, three-prong pliers, and universal pliers. And stainless steel wire, spot welding unit, soldering unit, silver solder, flex, wire cutter, finishing burrs, and polishing stones. Then moving on to the technique, whereas step 1 is band construction. Here, place separators interdentally and select the band material. Band is checked for 2 contrasting sides. About 2.5 inches is cut off with straight scissors. Band material is then slipped down the tooth and trial pinching is made with band forming pliers. Mark excess and cut it off and trim the excess and retry. The band carried by hoe pliers is placed down the tooth using the thumb. Seam is spot welded and festooning is done. Band is ready for final seating pinch the band with the beak pliers. Remove the band and spot weld the new contact, cutting the excess off. Fold seam in distal directions and remove it and solder the seam. Loop here same as the band and loop, but a stainless steel crown is used on abutment tooth instead of a band. Crown is used when there is extensive caries on more than one surfaces, fracture of tooth, developmental anomalies like enamel hypoplasia, amelogenesis imperfecta, dentinogenesis imperfecta, and etc. According to Christensen, this is not a recommended technique because this technique precludes the easy removal and replacement of the band. Then crown, band and loop. Here stainless steel crown is first placed on abutment tooth and then it is banded. It overcomes disadvantages of crown and loop space maintainer. According to McDonald's et al., it provides superior retention. Next modification is Maney space maintainer. Here band and loop, but the loop is halved with either buccal or lingual loop eliminated and the only one extension is given. The Maney space maintainer is used in cases where the abutment tooth is rotated, the permanent tooth is also erupting, when the loop is going to be a restriction for the eruption of the permanent tooth. Disadvantages of Maney space maintainer is tipping of the adjacent tooth. Next modification is band and loop space maintainer with unilateral band and bent wire design by Pushpalata et al. In cases with a space loss. Advantages include simple to fabricate, rigid and stable. It can be fabricated on partially erupted tooth and also on lingually tilted tooth. Maintains the space by preventing tipping of the two adjacent teeth. Long band and loop includes, it is used in cases there is multiple loss of teeth in one segment and an arch stabilizing space maintenance like lingual arch cannot be given due to eruption status or it is removable appliances is contraindicated. Next modification is reverse band and loop. when there is a premature loss of primary second molar and the permanent molars have not erupted fully to support a band. In such cases, primary first molar is banded and a loop is made that touches just below the marginal ridge of the permanent molars. Next modification is band and bar, which prevents the eruption of premolar, not used nowadays. Bonded band and loop. With the use of acid etch technique, light curing composite systems, simple space maintenance can be more readily made. Its advantage includes ease of adhesion to the dental contours, fast technique of application, good strength. But failure rate more because of prismless enamel in the primary dentition. Next modification is band and loop space maintenance with NIMS modification. Here, Prajapati et al. In 2013 proposed that in some cases like long-standing loss of upper first primary molar, the primary canine occludes with primary molar of opposite arch such that cusps of molar impede in space created by loss of tooth. In such cases, the loop has to be modified and one has to be removed to create space and allow proper occlusion. Next modification is band and loop space maintainer with occlusal rest. It is a modified band and loop space maintainer. A small occlusal rest is designed on a loop wire. This is placed to prevent the mandibular right first permanent molar from tipping and causing the wire to embed apically in the tissue distal to the first primary molar. Thus, the occlusal rest helps prevent the tipping motion of the first permanent molar. Next, moving on to a distal shoe space maintainer. It helps to maintain the space of a primary second molar which is lost before eruption of the first permanent molar. It was introduced by Willets in 1932 with bar-type gingival extension and modified by Roche in 1942 with a V-shaped gingival extension. The appliance design consists of metal or plastic guide plane along permanent molar erupts. Guide plane is attached to a fixed or removable retaining device and fixed appliance is usually retained with the band instead of a stainless steel crown. To be effective, guide plane must extend into 1 mm below the mesial marginal ridge at or before its emergence from the bone. If primary first and second molars are missing, the appliance must be removable, length of edentulous span and the guide plane is incorporated in a partial denture which provides occlusal function. Modifications of distal shoe include modified Willets space maintainer. It is a combination of distal shoe and lingual arch appliance and was suggested for use in patients in whom both primary molars are lost and patients with strong gag reflex and prevented the use of removable appliances. It is indicated in cases of bilateral loss of deciduous molars before the eruption of the first permanent molar, and the contraindications include in children of age 5 years 5 months to 6 years 5 months due to its possibility to create hindrance in the path of eruption of the permanent mandibular incisors. Advantages are less chair side time, less cooperation of the patient, fixed appliance thus increased stability and strength. Disadvantages are it is non-functional, does not help in mastication, fabrication is difficult, cannot be given in uncooperative kids. Dahl et al. In 2011 reported that modified Willets appliance fabrication required more laboratory time than chairside time when compared to the conventional distal shoe space maintainer. Lingual arch space maintainer, it is a bilateral, non-functional, passive or active mandibular fixed appliance. Most effective appliance for space maintenance and minor tooth movement in the lower arch. It is indicated to prevent the space created by multiple loss of primary molars, and it is indicated in bilateral loss of primary molars after eruption of the lower lateral incisors, and it is also indicated in unilateral loss of primary molars after eruption of the lower lateral incisors. And its contraindications include tooth movement or space regaining, rampant dental caries, high block scores or poor patient cooperation, anterior or posterior crossbite, and in cases with extreme mandibular anterior crowding or lingually erupting succedaneous teeth. The fabrication includes in mixed dentition, band placed on the permanent first molar, the primary dentition, primary second molar. It is not advisable to band on one permanent first molar on one side and a primary second molar on the other side. Adapt the band the same way as for band and loop space maintainer, and a complete arch impression is taken, and then the wire should be bent that it contacts the cingulum of the incisors slightly above the gingival, contacts the gingival third of the primary molars if it is present, and then runs parallel to the middle third of the molar bands. Its advantages include can be used in primary or mixed dentition as bands can be cemented to primary or permanent molars and can be used in hypodentia cases. It is very stable because of the two abutments. Disadvantages include if it is used in a primary dentition, the wire may obstruct the eruption of the lower incisors. Quadimet in 1998 reported that lingual arch space maintainer has the lowest median survival time of about 4 months. Its modification include removable lingual arch. It is a semi-fixed or removable space maintainer fabricated by welding a molar tube one on each side of the bands on the lingual aspect. The arch wire passes into the tube instead of soldering to the band. Then the part of the design, the band is fixed and the other part of the arch wire is removable. Next is lingual arch space maintainer with canine stoppers. Here, wire bent to create canine stops so as to create space for lingually erupting incisors. Fabrication is similar to lingual arch. The additional vertical canine stoppers are placed distal to the canine. The stoppers are made up of 0.7 mm gauge stainless steel wire which are soldered to the lingual arch. Next, moving on to the Nance palatal space maintainer, which was given by Nance in 1947. It is a bilateral, non-functional, passive, maxillary fixed appliance that does not contact the anterior teeth but approximates the anterior palate via an acrylic button that contacts the palatal tissue, which provides resistance to the anterior movement of the posterior teeth in an horizontal direction. Its indications are in cases of bilateral loss of multiple primary teeth where the permanent incisors have erupted. And it is also indicated as habit breaking appliances in case of tongue thrusting habits, and it should be used along with the spurs. Contraindications include in patients with deep bite, as the lower incisors tend to contact the arch wire on the lingual side of the maxillary incisors. Fabrication include maxillary first permanent molars are banded bilaterally. The second step is fabrication of the wire component using 0.036 inch wire. The arch wire is extended anteriorly without touching against the surface of the primary molars. At the rugae area, a small U-shaped bend is incorporated in the wire, which is approximately about 1 to 2 mm away from the soft tissue. The acrylic button, that is 0.5 inch in diameter, is placed on a descending portion of the palatal vault 1 to 2 mm below the incisive papilla. Advantages is effective space maintainer in maxilla. Disadvantages include accumulation of bacteria and food debris often results in palatal inflammation and sometimes pain. The acrylic portion could become embedded in the soft tissue if the palatal tissue hypertrophies occur because of poor oral hygiene or if the appliance is distorted. And the other disadvantages include soft tissue irritation, and the appliance cannot be used in patients who are allergic to acrylic. Baroni et al. In 1994 reported that Nance palatal arch maintained a constant survival rate of 70% at the end of 36-month interval. Rajab LD 2002 reported that decementation was one of the main reasons for the failure of Nance palatal arch space maintainer. Modifications include removable Nance palatal arch, which was given by Gianelli in 1991. Its indication is to maintain good oral hygiene over longer periods of wear. Fabrications include molar bands are placed on the upper first molar, following which the maxillary impression is taken. The exposed surfaces of band is covered with a thin layer of wax to facilitate removal from the cast. The sheets are welded to the palatal surface of the bands. Then the sheets are positioned as far apically as possible without contacting the gingival crest to avoid any occlusal interferences. The wires are bent so that they pass anterior to the rugae and can be incorporated into an acrylic button as with the standard Nance appliance. The loops are bent into the wires between the buttons and the attachments to allow the adjustment of the appliance. The finished appliance is then cleaned and polished. Advantages include it is easy to remove and reinsert. The removability of the appliance and the loop in the wires make fitting and adjustment simple. Disadvantages include patient complaints. Baroni in 1994 reported that removable maxillary arch space maintainers had longevity and success rates less than fixed maxillary space maintainers. Modified Nance arch for molar distalization, which was given by Rainer in 1992, who states that modified Nance button to distalize molars to prevent mesial movement of premolars and the incisors, and also after distalization to prevent mesial movement of the molars. It is indicated in bilateral missing deciduous molars in the upper arch and in distalization of the permanent first molars by incorporating a U-loop. Next, moving on to transpalatal arch space maintainer, which was introduced by Robert in 1972, a unilateral, non-functional, passive, maxillary fixed appliance for stabilizing the maxillary first permanent molar. It is indicated in multiple primary tooth loss on one side of the arch with other side of the arch intact, and it is indicated in derotation of the molars, aids in arch expansion, acts as an anchorage for the orthodontic treatment. Contraindications include class 2 malocclusion with upper first premolars are removed, and in class 3 non-surgical cases. Fabrications include maxillary first molars are banded bilaterally. The impression is made and cast port. 0.036-inch stainless steel wire is used to construct the appliance. Wire follows the vault of the palate, avoiding contact with the tissue and does not interfere with normal speech. Omega loop is incorporated in the center of the vault of the palate, which is oriented either mesially or distally. Wire soldered to molar bands, and then the omega loop in the center of the appliance helps in expansion, rotation, contraction and torque of the molars. Modifications: Zachrison type transpalatal bar. This was introduced by Zachrison in 2004. It has 3 loops. Middle loop is larger and longer. The additional smaller loops are symmetrically positioned on either side of the middle loop. The optimal length is about 89 mm. The size of the central loop is generally about 9 mm and the distance from the 2 farthest points is approximately about 12 mm. Can used to correct bilaterally rotated upper first molars. Next, moving on to vertical holding appliances, it is a modification with acrylic pad. The fabrication include maxillary permanent first molars are banded first. It is then connected with a 0.040-inch chrome cobalt wire with the dome-sized acrylic button at the sagittal and vertical level of the gingival margins of the molar bands. 4 helices are incorporated into the wire configurations for flexibility. Next, moving on to Gropper's appliance. It was introduced by Jasnin and Gropper in 1984. It is a fixed anterior space maintainer. It consists of an acrylic teeth attached to acrylic on the palatal wire. It is indicated in children suffering with premature anterior tooth loss due to early childhood caries, traumatic loss of primary anterior teeth, psychological benefits to the child, to manage speech difficulties and to aid in the mastication. Disadvantages include accumulation of plaque and debris, gingival inflammation associated with the buccal acrylic flange, occlusal disturbances, secondary caries due to cement loss in the primary molars. Chrysioglou in 2017 reported that Gropper's appliance exhibited 52.2% of success rate at the end of 24 months follow-up. The modern concepts of fixed space maintainers includes ribbon space maintainer, which is made up of fiber reinforced composite resin, usually developed to rectify the disadvantages of a conventional band and loop space maintainer. Next is EZ space maintainer. It is cost effective, less time consuming appliance than the traditional space maintainer. It does not require impression taking, no laboratory procedures, and can be bonded directly during a single dental visit. Next is Nichols appliance. It is a tube and loop appliance maintainer designed by Nikhil Srivastava et al. It is less time consuming and does not require impression taking, lengthy laboratory procedures and soldering like the conventional band and loop space maintainer. Next is Hedge appliance. It is a simple bracket and hook space maintainer designed by Hirojit Singh. This appliance does not require the lengthy procedure of band making, welding and soldering like the conventional band and loop space maintainer, and hence it is easy and quick to fabricate. Thus, I conclude the topic that there may be many types of space maintainers and their modifications. The pedodontists play a cardinal role in selection of the suitable space maintainer based on the clinical condition, oral hygiene and cooperative nature of the patients. Space maintainers form an integral part of preventive orthodontics, whereas no individual case is similar, hence judgment about the choice and the type of space maintainers must be governed by factors available from the literature and the presenting clinical situations. These are the references. Thank you for watching.